sharing with us. And please stay with us as long as you can as we transition to Dr. Knight, Dr. Margaret Knight, who's a associate minister of at Anderson Chapel in Macclesfield. She's going to guide us through the remainder of this program for breast cancer awareness. I know that normally we stop at 6 o'clock, but today, because we're covering breast cancer awareness, I do anticipate we may be running to 6:30. I know there are numbers of people that have a story they would like to share. We have Sister Gary Sherrod, hopefully that she would share. Tiffany, we want you to share, and Dr. Knight has some members that individuals that she would like to share. And if anybody has to go before that point in time, just kind of speak up and get our attention, and because we would like to hear your testimony. Dr. Knight, it's in your hands.
Good evening, everyone. To God be the glory for the great things that he has done. This is October, Breast Cancer Awareness Month. And why do we set aside a month to make ourselves aware of breast cancer and all the things that come along with it? And many of you who are on today understand the things that come along with it and know that they linger for a while. It doesn't just go away once the treatment ends, it lingers for a while. And so we celebrate it because we know that in Edgecombe County, Pitt County, and I believe Nash County, there is a high incidence of breast cancer. And breast cancer is the #2 killer of women. I think heart disease is the first. And so what we want to do is take the time to make everybody aware of the things they need to do to protect themselves and to protect their families and to make sure that their future is bright. And so I'm not going to waste any time. I'm going to go to my nurse navigator from the Vidant Cancer Center, Deborah. And Deborah, I'm not going to pronounce your last name, because I don't want to mess it up. But what I do want to do is go straight to Deborah and allow her to share with us some things. She worked with me through both cancers in 2013 and 2020. And also she has been working with patients during this pandemic. So Deborah, at this time, I ask you to just come and share with us some things that you have about breast cancer.
Thank you, Margaret. Can everyone hear me?
Yes.
Yes, we can hear you.
I want to thank you for the opportunity to be able to be here today and to share. We certainly need the faith community to help us get the word out and to help us overcome the disparities that we see in our population. I'm a breast cancer navigator. I've worked in oncology for 23 years, and I've been a breast cancer navigator for 14 years. And I'm very passionate about cancer care. I became a nurse after my father died from liver cancer. So it's something that's very, I'm very passionate about. Just want to tag on to the last speaker in regard to vaccines for cancer patients. So we've had a lot of phone calls to the cancer center asking if, patients ask me if they can get the vaccine, if it's okay for them to get the vaccine. And national guidelines came out last year when the vaccine became available that the national guidelines do recommend that cancer patients receive the vaccine. There are a very small number of cancer patients that they would not want to get vaccinated. Someone earlier in the call mentioned a cancer treatment that a patient went through where they had to get revaccinated, and that's called a stem cell transplant or a bone marrow transplant. And that does completely wipe out your immune system completely, and you're starting fresh. And all those patients that undergo stem cell transplant do have to be revaccinated. So there's a few patients in that population where you might want to hold off on the vaccine. But most cancers, including breast cancers, even patients that are undergoing treatment, we recommend that they get vaccinated. If we have the opportunity to vaccinate them prior to starting treatment, that's even better. So it doesn't harm patients to get the vaccine while they're undergoing treatment, but the likelihood that they will develop immunity from the vaccine is lowered if their immune system is lowered from the treatment. So although it doesn't hurt them, the vaccine effectiveness may be lower than what it shows in the clinical trials because their immune system is stunted from the treatment. So we are encouraging all of our patients to get vaccinated, even the ones undergoing active treatment in most cases. And as far as the boosters, because we're getting a lot of questions about boosters and whether our patients should get boosters, and we are recommending boosters for any of our patients that are undergoing active treatment of any type for their cancer. So I just wanted to address those vaccine questions in regards to cancer. I'm a nurse navigator at Vidant Cancer Care. And at the Vidant Cancer Center, we do have a multidisciplinary team that takes care of breast cancers. And this would include surgical oncologists, medical oncologists, radiation oncologists, as well as a navigator. And I have some lay navigators that work with me that I've trained in breast cancer, two of which are survivors. We have a pharmacy team. We also have support teams such as social workers, licensed clinical social workers, and nutritionists. We also do have some support groups that we can offer to cancer patients. So cancer is a disease for not only the patient, but the family as well. So we try to do our best to support patients while they're undergoing treatment. As a navigator, I work to try to overcome barriers to care. So I work with patients to individualize assistance to them and their families to help overcome healthcare system barriers so that they can have access to their medical care. And that's my primary goal as a navigator. Now I'm just going to kind of talk a little bit about breast cancer in general and give you some statistics. I didn't have time to update a presentation to have the numbers from this year. So the numbers that I'll be sharing are from 2019 and 2020. But breast cancer is the most common cancer in the United States, excluding skin cancers. And it's the second leading cause of cancer death. The highest is in lung cancer. And the incident rates have increased slightly per year, less than 1%, about 0.4% from 2006 to 2015. There are over 2.5 million women living with breast cancer in the United States now. And the risk is about 1 in every 8 women in their lifetime will develop breast cancer, and that's about 12% of the U.S. population. And of the people that develop breast cancer, 1 in 33 will die of their disease. And in 2019, it was estimated that there were about 8,900 women that would be diagnosed with breast cancer in North Carolina. In the United States, there was a total of about 269,000 women that were diagnosed with invasive breast cancer. And on top of that, about 63,000 that were diagnosed with a really early stage breast cancer called ductal carcinoma in situ. And men can also get breast cancer. There's usually about 2,700 men diagnosed with breast cancer in the United States per year. In deaths, we have used about little over 4,200 deaths from breast cancer every year. That includes both men and women, the majority of which are women, with about 500 cases of men that die per year. The death rates for breast cancer have declined significantly since 1989. The death rates have actually decreased by 40%. And that's due to early detection and improving treatments for breast cancer. I have seen tremendous strides in the treatment of breast cancer just since I have worked in oncology in the last 20-something years. So the survival rate back in the 70s, the survival rate for breast cancer was about 75%. Now it's about 90% today. The current 5-year survival rate overall for all women, including all stages, is about 90%. But women that are diagnosed at local stages where their breast cancer is confined just to their breast, their 5-year survival rate is 99%. And women that have breast cancer that spread to the regional lymph nodes, meaning to the lymph nodes underneath their arm, the 5-year survival rate is 85%. But for women that wait and don't go in, and that a lot of times these women know something's going on, but they wait because of fear, and come in at late stages where their cancer has already spread to distant sites, their 5-year survival rate is only 27%. But we do have some disparities, in cancer care. So women that are African American have worse survival and worse outcomes than women of other races. And I think this has to do with the disparities, in care. So if you look at the survival rate for 5-year survival rates for all stages, at 5 years, white women, 92% of them are still living. But African American women, only 83%. So we certainly have some work to do as far as disparities are concerned to try to equal those numbers out so that, everyone, can have the same survival rate. So what are the risk factors for breast cancer? Well, number one is being a woman. Breast cancers also increase with age. So most breast cancers happen over the age of 50, and it increases as you age. Personal history of breast cancer. If you've had a biopsy or an abnormality in your breast, and the pathology showed something called atypical cells, you have an increased risk of developing breast cancer. If you started your periods at a very young age, or you went through menopause at a very late age, then you have a longer exposure of estrogen over your lifetime, which can increase the risk of breast cancer. If you've had a family history of breast cancer, you have an increased risk. And also women who have had, or men who have gene mutations that increase risk of cancer. So the most common ones that a lot of people are familiar with are the BRCA1 and BRCA2 mutations. They are the first ones that were discovered back in the 90s. And they account, genetic alterations account, we believe, for about 5 to 10% of breast cancers. There are actually large gene panels that we now do for patients that we believe may have a genetic risk. There are actually about 84 genes that we can check for now that are associated with increased risk of cancers, not just breast cancers, but other types of cancers. So we're coming a long way in the genetics realm to know who may be at risk for certain types of cancers. Patients who have been exposed to radiation, or people who have had cancer and have been exposed to radiation therapy, especially at young ages, to their chest, are at increased risk of developing breast cancer. Women who have a high bone mineral density have increased risk of breast cancer, and that's related also to the estrogen exposure. Women who have denser breast tissue, and this is something that they make a note of in the mammogram report. So the size of the breast does not matter, but the breast density does. So having dense breasts is a risk factor for developing breast cancer over women who don't have real dense breasts. Breast also makes your mammograms more difficult to read. We do have better mammography technology now than we used to. Most of the centers here in Greenville use 3D technology, and they're you can see the pictures a little bit better, gives you a little bit more detailed picture of the breast. But some women who have very, very dense breasts may be recommended for other imaging like MRI. Women who have diabetes type 2 or who have had a diagnosis of lobular carcinoma in situ or atypical ductal hyperplasia also have an increased risk of developing breast cancer. Going to sleep tonight, ain't got. So there's a few risk factors that you actually have control of in regards to breast cancer risk. Number one is smoking. Also, alcohol consumption. So people don't associate that with increased risk of breast cancer, but alcohol consumption in large amounts is linked to increased risk for developing breast cancer. Women who have their first child over the age of 30 have an increased risk of breast cancer. Women who breastfeed for at least 1 year have a decreased risk of breast cancer. Avoiding exposure to estrogen in birth control pills and hormone replacement therapy. Women who have been on those for a number of years have some increased risk of developing breast cancer. And also obesity is linked to increased risk of breast cancer. So a healthy diet and exercise can decrease breast cancer risk.
Deborah, does that conclude what you have for us?
No, I have a little bit more. I'm sorry. I was just getting my notes ready. I'm sorry.
Okay.
So, I wanted to talk a little bit about early detection as well. So early detection is one of the key things in breast cancer because, as I said earlier, the earlier you're diagnosed, the better the prognosis. So early detection improves the chances that breast cancer can be treated successfully with fewer treatments and more treatment options, less extensive surgery, and also better treatment outcomes. So 98% of women who are diagnosed with breast cancer in their earliest stages, will do better and have a better survival, whereas only about 24% will survive disease if they're diagnosed at a more advanced stage. And there's a lot of controversy out there in the recent years about mammograms and when you should get your mammograms. And there are a number of different guidelines out there, and a lot of people don't know which guidelines to follow. The National Cancer Guidelines do recommend starting mammography at age 40 and having mammograms every year. And we know for a fact that does decrease mortality from breast cancer starting at age 40. A lot of the guideline controversy came from a study that came out from the National Task Force, where they were talking about having false positive mammograms and the harm of that. Well, the harm in that is actually having to do further workup. But if you look at actual survival and mortality, okay, that you get better, you get earlier diagnosis if you go and get your mammograms early, and you get them every year. And the study that they did with that national task force and the data that they were looking at was actually old data where we were using older forms of mammography where people had to be called back more often than they do now with the newer technology. And, the only harm is, that it's going to scare somebody to go get a workup that they might have to get, called back for extra imaging or a biopsy that comes back to finally be negative versus, not having that mammogram and then their cancer being diagnosed at a later stage because they didn't go get their mammogram. So, as a breast navigator, I recommend that patients follow the guidelines that we would at the Cancer Center, which are the radiology, the national radiology guidelines, which would recommend breast cancer mammograms starting at age 40. And every year up until you reach an age where your life expectancy is such that you wouldn't live enough for it to be worth it. Are there questions about any of that? Laura? And those, are guidelines that are for people that are at average risk. Some women have a higher risk because of their personal history or having relatives that have had breast cancer or gene mutations that make them at risk for breast cancer, which would need more, closer scrutiny and more follow-up and mammogram than the normal population would. And I do want to tell you, because there are a lot of women, and we're talking about disparities and trying to get women to go get their mammograms, but if they don't have insurance, then a lot of times they don't have the ability or can't afford to get their mammogram. There's a wonderful program. It's actually a national program, and we do have it in this state in almost all the counties, and it's called the Breast and Cervical Cancer Control Program, or the BCEP program. And it's a screening program for women, and it covers women from ages 40 to 64 who are uninsured. The income guidelines are pretty liberal, to 250% of the federal poverty level, so a lot of women can qualify for it. And it will cover their mammograms and their pap smears for free. They do have to re-enroll in that program every year to stay on the program. And the other wonderful thing about that program is if you're screened through that program and you get diagnosed with a breast or cervical cancer, you actually convert over to get BCEP Medicaid, which would cover that woman until they've completed their cancer treatment. So not only does it cover the screening, but it enables them to have insurance that would cover their treatment until their treatment is completed. And most of the programs in the state are through the local health department, but there are a few others. But you can go onto the website. I think it's bcc2.nc.gov, or just Google North Carolina BCEP, and the information will come up with all the contact numbers for all the different counties. But I highly encourage, if you know anyone that is uninsured and needs to get their mammogram or pap smear, to refer them to that program so that they can get their mammogram. And I'm just going to talk a little bit about signs and symptoms of breast cancer. So the most common symptom is a breast lump or thickening in the breast or under the arm. You could have nipple tenderness, discharge, or kind of scaliness of the skin. Breast pain is not a very common symptom of early breast cancer. Usually when you're having pain, most of the time that's related to more advanced breast cancer. If you have any kind of dimpling of the skin, scaliness, unusual creases in the skin or puckers in the skin, then that is a reason to go into your healthcare provider. Breast cancer can also present almost like a breast infection, where you can get warmth, redness, or swelling of the breast with an appearance of the skin tissue almost looking like an orange peel. And that is a very aggressive type of breast cancer called an inflammatory breast cancer. If you're having any changes from one side to the other, so if your breasts are normally the same size and you're noticing a change in the size of one breast to the other, that's a warning sign. Any discharge from the nipple or changes in the nipple, any swelling underneath the arm or in the arm can be a sign of a more advanced breast cancer. But any kind of you're feeling, we do recommend they do recommend now that women are familiar with their breasts. They're not saying to do breast self-exam, but you're not going to really be familiar with your breast if you're not doing a breast exam. But I do recommend women do breast exams, and if you're noticing anything that's changing, you need to go to your healthcare provider. The only way that you're going to notice if there's a change is if you are doing an exam regularly and you know what your normal is and if there's a change in that. Advanced signs of breast cancer could be things like pain anywhere in a bone, like the shoulder, the hips, the back, or the pelvis, a persistent cough, unexplained weight loss, nausea, vomiting, or GI upset, dizziness, blurry vision, headaches, or difficulty walking. And those are all signs that the cancer has actually spread to distant sites. And very tragically, I do see, usually several patients a year that have waited to the point where they have symptoms like this before they seek medical care.
Thank you, Deborah. You have given us so much information that we can use to guide ourselves and our loved ones as to how to address different symptoms and what have you. And we just thank you so much for joining us on this afternoon. And I realized I talked to you at the last minute. I had the wrong number. I was calling the wrong number, but thank you so much for sharing. This time we're going to go into some testimonials. And Deborah, we hope that if you can, that you can stay on and hear some of the testimonials. We're going to begin with